Hello, my name is Peter Acker. I'm a clinical instructor in the Department of Surgery and Emergency Medicine at Stanford University. And today we'll be talking about a case of anaphylaxis. This is part 2, describing a young gentleman, a 33-year-old, who came in to see us with lip swelling and abdominal pain, both of which were sudden onset after a bee sting. On our initial evaluation, we found him to have some vital sign abnormalities, and he was pale appearing with a swollen lip and some respiratory distress. As of yet, we've placed him on oxygen with a cardiac monitor, and we've placed an IV. So we'll pick up from there. So on our initial assessment, we found some red flags or warning signs from the evaluation and examination that could potentially indicate life-threatening conditions. So we found he had airway edema, he had some respiratory distress, and he had low blood pressure. So we found abnormalities with all 3 components of the ABC assessment. So this patient is clearly sick. So at the end of last case, we were finished by reevaluating and gathering a little bit more information. Now it's time to think and develop our differential diagnosis. So there's a number of items on the list to consider. So he may potentially have a type of distributive shock. This could potentially be sepsis or anaphylaxis. He may have carcinoid syndrome that can produce a number of these symptoms, as well as scombroid poisoning. Asthma could potentially be contributing or causing his symptoms. This may be a form of cardiogenic shock, congestive heart failure, or a form of hypovolemic shock. So we have a number of items to consider, and let's see if we can refine them a little bit. In order to do so, we'll look at each piece of the patient's presentation and determine if the differential fits or not. So we have the differential diagnosis listed at the top of this table, and we'll examine the symptoms that he presented with. So we noticed he had low blood pressure. This can occur in a number of these presentations, not often with asthma. However, many of the other ones can have low blood pressure. We also noted him to have wheezing. This is also a common feature with a number of these presentations. It may even present in sepsis if the lungs are the source of infection, or cardiogenic shock with pulmonary edema can sometimes have wheezing. Flushing can be seen in a number of these: carcinoid syndrome, scombroid, anaphylaxis, or sepsis. Rash similarly can present in those same conditions. Abdominal pain is also fairly common. It can present in sepsis if there's an intra-abdominal source of infection, but definitely in carcinoid, scombroid, and anaphylaxis. Mucosal edema is less common. We see that really just in scombroid poisoning and anaphylaxis. And the last component is his exposure to a known allergen. And this really only happens, out of all these diagnoses, in anaphylaxis. So there's a number of diagnoses here that are, we see a number of the symptoms that are commonly occurring. However, anaphylaxis is the only one that seems to tie all of them together. So now that we have a refined differential diagnosis, we want to ask ourselves, what test should we order to prove or disprove our diagnosis? We have any test available to us, radiology tests, lab tests, EKGs, anything that we think would be helpful. So it's our job to determine which of any of these are going to be helpful for this patient. So a caution, anaphylaxis is actually a clinical diagnosis. No testing is actually needed. And any patient who appears to have anaphylaxis should be treated as such until proven otherwise. So anyone with this presentation, we should treat them as if they have anaphylaxis until we find another diagnosis that fits better. So how do we actually diagnose anaphylaxis? What are the criteria? And there's a couple. We'll try and simplify it as much as possible to make it easy to remember. The first diagnostic criteria involves acute onset of symptoms after a possible allergen exposure and involvement of 2 organ systems. These organ systems can be skin or mucosa. Those are considered one organ system in this definition. The pulmonary system with any signs of respiratory compromise, reduced blood pressure, which would be a manifestation of cardiovascular compromise, or persistent GI symptoms. For instance, in this patient, the abdominal cramping. The second diagnostic criteria is fairly straightforward. It involves exposure to a known allergen and hypotension. In this case, for these guidelines, hypotension is defined as a systolic blood pressure less than 90 in adult patients, or a decrease of greater than 30% from their baseline blood pressure. For infants, they define low blood pressure as a greater than 30% decrease in their normal systolic blood pressure based on age-specific guidelines. So again, that's a known allergen exposure in the setting of reduced blood pressure defines anaphylaxis. So in order to further simplify, allergen exposure plus 2 organ systems involved is anaphylaxis, or allergen exposure plus hypotension also equals anaphylaxis. So let's put it all together for our patient. He certainly has more than 2 organ systems involved. He has airway edema, he has a rash or skin mucosa involvement. We noted him to have respiratory distress, abdominal pain, and low blood pressure. So at least 4 or 5 organ systems involved, including low blood pressure, plus a known allergen exposure. He was stung by a bee, and he was known to have allergy to bee stings. So this gentleman definitely meets the criteria for anaphylaxis. So based on our ongoing assessment and thoughts, we need to determine what further interventions are essential for this patient. And they're going to need to be targeted at the abnormalities we found on the ABC exam. So we already have him on some supplemental oxygen, a cardiac monitor, and we have an IV in place. The next step should be targeted at airway, breathing, and circulation. So for airway, our next intervention should be bringing advanced airway equipment to the bedside. This patient appears to need intubation, and so we should prepare for that. We should also create a plan as far as how we're going to do this, as this will likely be a difficult airway. For breathing, the patient was already on supplemental oxygen. Let's put him on a face mask to increase the amount of oxygen he's getting to support his cardiovascular function, and also pre-oxygenate him prior to intubation. For circulation, the most important treatment that we're going to give this gentleman will be intramuscular epinephrine. This is the first-line treatment for anaphylaxis. The initial dosing is 0.3 milligrams intramuscularly. There's really no use for subcutaneous injections. The uptake is not that good, so we prefer intramuscular. And the lateral thigh is preferred, as the uptake of the medication is more rapid from that site. The next component of supporting his circulation will be giving a bolus of intravenous fluids. We usually start with 1 to 2 liters rapidly. And lastly, we can help his circulatory function by optimizing his position. We like to lay these patients flat, elevating their legs, which helps bring blood from the lower extremities to the core and the vital organs. So another caution, delays in epinephrine administration can be fatal. Early epinephrine is very critical for patients with true anaphylaxis. And there are no true absolute contraindications to epinephrine in anaphylaxis. Even patients with coronary artery disease, if they have true anaphylaxis, deserve epinephrine, as this is the treatment of choice. So the summary for this portion of the case is that anaphylaxis is a clinical diagnosis. No testing is required. They have to meet one of the criteria, either exposure to a known allergen and low blood pressure, or exposure to an allergen and 2 organ systems involved. And lastly, early epinephrine saves lives. This is the first-line treatment for anaphylaxis.